So moving on, presenting for us today, we have two presenters. So we have Dr. Cyrus Ho. He's coming to us from Singapore. He's the assistant professor and senior consultant psychiatrist at the National University of Singapore and the National Hospital of Singapore. And then we also have Cynthia Kim, who's a licensed clinical social worker. She's the director of behavioral health at the University of Hawaii Family Medicine Residency Program. So we've got a lot of information coming to you today, and we're going to go ahead and start off with Dr. Ho.
Hello, hi, good morning, everyone, from Singapore, and probably good afternoon to you all from other parts of the world. So I'm Cyrus, I'm from Singapore, and the title of my presentation today is the mental health aspects of long COVID and neuropsychiatric, perspective. Sorry, just give me a minute. Okay. So although global COVID-19 infection rates have significantly declined due to vaccination, improved treatments, and population immunity, but we know that the pandemic's neuropsychiatric footprint has not faded. In fact, there is still a growing number of individuals continuing to experience persistent symptoms, which includes things like fatigue, cognitive impairment, anxiety, depression, and sleep disturbances, and these are collectively described as long COVID. So this matters because we know that these symptoms disrupt functional outcomes long after the viral clearance. It strains healthcare systems, social systems, and actually challenges our traditional boundaries between neurology, psychiatry, and immunology. So as clinicians and researchers, we cannot view COVID-19 as just an acute respiratory illness. Rather, we should try to understand more about its long-term impact on the brain and the mind. And today I will explore the neuropsychiatric implications for care, rehabilitation, and public health. And we do want to be able to know more about it so that we can actually help in terms of the mental health outcomes.
Dr.
Iris,
Ho.
I'm so sorry, but it looks like your slides are not advancing.
Oh, I'm not advancing yet. Yeah, I'm just talking.
Oh, okay, okay.
Yeah. So it's advanced. Yeah. So these are I have no disclosures. And this is the overview of my presentation. So I'll start off by giving a very broad overview of the neuropsychiatric sequelae of COVID-19 infection, and then zoom in to talk about some of the mechanisms of how the coronavirus induces neuropsychiatric symptoms, and then specifically focusing on mood disturbances, cognitive functioning, as well as fatigue, and lastly, to give a broad overview about the management of these various symptoms. So you can see that, from this systematic review of 33 studies, it shows that depression and anxiety are among the most common neuropsychiatric sequelae of COVID-19 infection. And depression is reported about 10 to 68% of patients, anxiety about 5 to 55%, and there is a wide range in terms of the prevalence, simply because perhaps differences in illness severity, the follow-up methods, and also population characteristics. But you can see that the key risk factors for depression and anxiety include perceived stigma, previous psychiatric history, persistent physical symptoms such as breathlessness, reduced quality of life, and loss of smell. And interestingly, even those with mild illness, especially women and older adults, they remain vulnerable, and persistent anosmia is a consistent marker. So it's also important to recognize that the mental health symptoms that people present with are not limited to those who are just hospitalized. In fact, many non-hospitalized patients do report similar or even higher rates of depression and anxiety, but this could be because they're receiving less structured support and follow-ups. So beyond depression and anxiety, we are also seeing acute and post-traumatic stress symptoms in about 10 to 36% of patients, especially those with previous history of psychiatric history, women, and people who have close family members who were infected with COVID. And these symptoms tend to be more common in patients who were hospitalized, perhaps due to some, frightening experiences in isolation or ICU settings, while older retired individuals seems to experience lower distress. Psychosis is much rarer at about 0.4%, and I have clinically seen it in my clinic, perhaps a few cases. So they're not that common, but it is important to recognize that people with pre-existing psychotic disorders such as schizophrenia, delusional disorders, especially in their 30s to 40s, may be at a higher risk. And this could be likely due to inflammation, steroid exposure, or severe sleep disruptions. And lastly, insomnia, perhaps it's also one of the very common symptoms encountered, and is frequently associated with medical comorbidities, females, and those with psychiatric illnesses. Then cognitive impairment is often referred to by patients as brain fog. At fatigue, these two are very broad and common complaints seen. One thing to note is that cognitive impairment can be quite difficult to quantify because it can be rather subjective and is often based on subjective experiences, as you know. And it is important for us to do objective testing. But either way, it affects concentration, memory, work performance. And fatigue is reported, ranging from 13% all the way to about 89% of patients, and it's one of the most persistent and disabling symptoms. And it is important to recognize that fatigue is not just tiredness, and it is an exhaustion that affects daily functioning and recovery. It's important to recognize that these symptoms arise from multiple contributing factors. So besides from the physical symptoms of shortness of breath, cough, immobility, reduced physical capacity, which plays a role, but at the same time, political, social, financial stresses during the pandemic can actually cause widespread uncertainty. And of course, we have biological, factors coming in as well that compounds each other. So there is this emerging evidence suggesting a biological basis, either from a direct viral effect or from an immune response, which I will talk about in the next few slides, interacting with psychosocial stress. And this may explain why some of these symptoms are quite prolonged and fluctuating and difficult to treat. So this slide shows how the coronavirus actually induces neuropsychiatric symptoms. So essentially, the virus binds to the angiotensin converting enzyme 2, which is the ACE2 receptor, causing internalization and then starting the virus reproduction cycle. So the ACE2 receptor is located on the surface of diverse cell types, including neurons, astrocytes, endothelial, and smooth muscle cells of several blood vessels, as well as skeletal muscle cells. So in many of the viral infections, immune cells usually can detect the pathogenic RNAs and activate an inflammatory response, which then triggers a wide range of effects that tries to contain the spread of the pathogen. But for the case of the coronavirus and COVID, it can overcome this containment, which results in a positive feedback loop between the viral propagation and the release of cytokines and chemokines. So what happens is that, with viral propagation, the release of cytokines and chemokines were increased, and then there is this mutual amplification causing the disease characteristic cytokine storm, which you may have heard about. And during this cytokine storm, what will happen is that there's an increase in critical cytokines such as interleukin-6, tumor necrosis factor alpha, interleukin-1 beta, among others. And studies have shown that all these cytokines tend to increase in greater quantities in vitamin D3 deficiency. And what's happening next is that, okay, when this cytokine storm is formed, it causes destruction of the tight junctions at the endothelial lining of the blood-brain barrier. And this increases the blood-brain barrier permeability, allowing transmigration of virus-infected leukocytes into the CNS. And then this can further activate platelets, adhesions, causing endothelial impairment, leading to thrombolytic risk that we often see in COVID infection. So this slide just shows what I have described earlier, okay, in terms of acute infection by causing disruptions in the blood-brain barrier. And then what happens to long COVID conditions then? So there are several proposed mechanisms to explain how the coronavirus can lead to persistent neuropsychiatric symptoms. Firstly, we know that chronic inflammation plays a central role, and persistent low-grade immune activation can drive secondary degenerative processes in the brain. So certain brain regions, as you can see over here, are particularly vulnerable because they are reached in the ACE receptors, which is the entry point that the virus used. So these areas includes the somatosensory cortex, the orbital gyrus, the temporal lobe, the hypothalamus, the thalamus, the brainstem, and the cerebellum. And studies, okay, using PET scans in long COVID patients have shown that there is a reduced glucose metabolism in these areas, reflecting impaired function. And this hypometabolism may be further driven by oxidative stress, mitochondrial disruptions, impaired cerebral autoregulation, and all these mechanisms can disrupt energy supplies and neuronal health. And of course, we know that all these systemic effects occurs and interact synergistically. So just now we talked about endothelial dysfunction, hyperinflammation, autoimmunity, latent viral reactivation, multiple organ involvement, autonomic nervous system dysregulation. All this can contribute to the symptom burden. So the WHO has defined long COVID or post-COVID conditions as the continuation or the development of new symptoms 3 months after the initial infection, lasting for at least 2 months with no other explanations. So this highlights that these symptoms can persist well beyond the acute phase and cannot be simply contributed by recovery time. And based on the meta-analysis of 51 studies, it identified the most common neuropsychiatric symptoms to be insomnia in about 27%, fatigue in 24%, cognitive impairment in 20%, anxiety in about 19%, PTSD 15%, and depression in about 13%. And we know that all these symptoms can significantly affect daily functioning, work productivity, and quality of life. And risk factors, are similar to those that I mentioned during the acute phase, female gender, greater illness severity, yeah. And although prevalence tends to decrease gradually over time in terms of the long COVID symptoms, but the decline is not really as steep as what we expected it to be. So in particular, persistent anxiety, low mood, and sometimes poor sleep appear quite recalcitrant, remaining long-lasting in some individuals. And this suggests that for a subset of patients, the mental health of the COVID-19 may become a chronic burden that we as clinicians and healthcare systems need to recognize. So this slide just summarizes findings from a recent meta-analysis of 113 studies of patients with long COVID. And once again, depression and anxiety were consistently and significantly associated with long COVID. Odds ratio about 2.35 and 2.53 respectively. So meaning to say that actually patients with long COVID are more than twice as likely to experience depressive or anxiety symptoms compared to those without it. And then when we try to compare affected patients to controls more directly, the effect size remains substantial. So meaning to say that these symptoms are generally elevated in this group. And many studies also have pointed to maladaptive psychological factors as predictors of persistent symptoms, such as poor emotional regulation, catastrophizing, dysfunctional expectations, and all this can amplify symptom perception and prolong distress. But there are also quite a lot of evidence gaps. So many of these studies were cross-sectional. So we do need prospective data to understand causality and trajectory over time. Then, in terms of the causes, so there are several pathways on how the virus can contribute to mood disturbances, particularly depression. So we know that many patients actually experience significant psychosocial stresses like fear of the illness, social isolation, job insecurity, stigma, which all can directly impact mood. And talking about from the biological perspective, the virus can definitely affect the brain directly or indirectly through exaggerated immune responses known as the cytokine storm. And this immune activation can trigger neural inflammation closely linked to depressive symptoms. And we know that depression in itself is a chronic inflammatory illness. So the cytokines can affect the brain in various ways. So either through hyperactivation of the hypothalamic pituitary adrenal axis, the HPA axis, leading to elevated cortisol, downstream effects like neurotoxicity, neurodegeneration, disrupting synaptic plasticity, impairing the brain's ability to regulate emotions and form healthy neural connections. And um, and many studies have also found that cytokine blocking agents, right, such as anakinra and tocilizumab, may actually offer some form of protection against the development of depression at the 3 months mark, highlighting potential immunological contribution to mood dysregulation. Then, in terms of cognitive impairment, it seems to be largely driven based on studies by inflammatory processes once again. So levels of cytokines such as the interleukin 6, TNF alpha, IL-1 beta have found to increase significantly, and it tends to worsen in people who are deficient in vitamin D. And we know that IL-6, TNF alpha are able to cross the blood-brain barrier, activate the microglia, which is the brain's immune cells. And once they are activated, they will release the IL-1 beta. And IL-1 beta particularly are highly concentrated in the hippocampus, which are the regions responsible for memory formation and learning. So this means to say that our hippocampus are actually very vulnerable to inflammation. And with the elevated IL-1 beta, has been shown to impair neurogenesis, interfere with long-term potentiation, and weaken memory encoding. And studies have also found that attention and working memory are affected. So TNF alpha, IL-1 beta can disrupt normal neuronal firing processes and patterns, leading to distractibility, difficulty in focusing, slower information processing. Then we talk about the ACE2 just now, which is the key receptor that the virus used to enter the human cells, including those in the brain. So, but beyond it being a viral entry point, for the coronavirus, the ACE2 actually normally helps to regulate healthy brain functions as well by stimulating the BDNF, which is the brain-derived neurotrophic factor. We know that the BDNF is crucial for maintaining neuronal health, so reducing microglial activation, preventing excessive inflammation, supporting the growth and survival of neurons. And BDNF levels, when they are low, there are issues with memory, learning, and overall cognitive performance. So when the coronavirus binds to the ACE2, it can interfere with its normal signaling, and this reduces the ACE2-mediated BDNF activity. And then, one hypothesis is that the viral spike protein can act as a competitive antagonist, blocking the ACE2 availability and affecting the downstream BDNF pathways. So this slide just brings together several of the mechanisms that we have discussed about to show how the virus can lead to cognitive impairment. So as I mentioned earlier on, the virus triggers off a cytokine storm, increases IL-6, and IL-6 makes the blood-brain barrier more permeable, increasing the inflammatory molecules from the bloodstream to enter the brain, activating microglia. And then at the same time, astrocytes are activated and then adding to the inflammatory signaling pathways. And then more of these immune cells are activated through toll-like receptor stimulation. And all this worsens when BDNF levels also decreased, as we discussed earlier. So objective cognitive impairment has been documented, in a substantial proportion of patients after COVID. And roughly about 15 to 40%, of individuals actually showed some form of, cognitive performance declined from the first 10 days to about 105 days after hospital discharge. And another systematic review actually showed a prevalence that's even higher, up to about 66.8%. So suggesting that cognitive impairment is actually not that uncommon, and it could potentially be under-recognized. And most of the issues that people faced are sustained attention, executive functioning, visual spatial processing, memory, and language. And then, of course, people who require ICU stay actually are at particular higher risk of executive dysfunctioning. Then patients with certain clinical features have been linked to later cognitive difficulties, such as those requiring oxygen therapy, tend to score much lower across a wide range of cognitive domains, reflecting perhaps the impact of hypoxia, inflammation, and the severity of illness as a major predictive factor. Neurological symptoms during the acute phase, such as confusion, dizziness, neuropathic complaints, were also associated with lower working memory scores later on. Headaches were linked to deficits in memory coding, attention, and complex working memory. And even diarrhea has been found to be associated with lower performance in delayed visual memory and working memory, which perhaps also tends to highlight perhaps the gut-brain axis and the systemic nature of COVID-19's effect. Then for self-reported cognitive functioning, so many people reported subjective declined and roughly about 19 to 34% of participants describing forgetfulness, difficulty recalling recent events, or word-finding difficulties. Attentional problems is a big problem as well. Then there is a growing body of evidence linking COVID infection to subsequent cognitive impairment based on studies, and even in cases that are not that severe. So this is a study that looked at 785 UK Biobank participants, 51 to 81 years old, who received brain scans and cognitive testing as part of the Biobank's data gathering. And they found that about half of the population actually tested positive for COVID after the data were collected. And in both groups, they actually scanned their brains before and after, and cognitive tests were done. So what they found was that even patients with mild COVID-19 infection that did not require hospitalization actually showed changes in the brain on imaging. So these changes were more pronounced in regions involved in smell and memory networks, such as the orbitofrontal cortex and the parahippocampal gyrus. And there's also a greater gray matter thickness reduction, more atrophy, and signs of tissue damage in those related to the olfactory cortex. And they also showed significant cognitive impairment based on cognitive testing. So although the neuroimaging differences seems to appear to be fairly modest, roughly around 2% difference, but this study was only done showing a difference across 5 months. So with measurable cognitive impairment. So this suggests that actually things could potentially be more, if we actually look at them longitudinally. And these regions are very crucial. So mild infections of COVID may not entirely be that benign after all. And for this particular study, they also excluded patients who were severely ill, so those who were hospitalized. And this suggests that the neuroimaging findings suggest that the possibility of neurodegenerative process is actually quite real. And then this is another study that looked at the longer term trajectory of 1 year after COVID-19, and they actually excluded participants with pre-existing cognitive impairment, history of dementia, serious chronic illnesses, to want to really look at the actual effect of COVID on the cognitive functioning. So what they found was that over 1 year, the rates of cognitive decline were comparatively much higher. And early onset mild cognitive decline was nearly 5 times more likely in COVID-19 survivors. And a progressive severe decline was 19 times more likely in people who were, as compared to those who were never infected, right? And increasing 1.7 times, okay, for early onset declined, for even non-severe, okay, infection. So when you scale these numbers, okay, to hundreds or millions of infections worldwide, you can see that, okay, it does, okay, contribute, okay, to future, okay, dementia or cognitive impairment burdened. And this underscores our need for early screening and rehabilitation. So moving on to fatigue, is the most commonly reported symptom both during acute and long after recovery. So prevalence can be fairly high, even up to about 90% with severe fatigue. And when we look at the pooled data, 1/3, okay, of them, okay, still experience fatigue 12 weeks or more after diagnosis. And interestingly, more females than males report fatigue, although the difference is not statistically significant. And adults tend to experience more persistent fatigue than children. Yep. Then once again, okay, fatigue in itself, right, is not simply a marker of disease severity. It's because people who are not as severely ill also had fatigue long after, okay, the infection. And we have to recognize that fatigue is multidimensional and contributed by many pathways, from biopsycho to social. And this may also explain why, okay, fatigue is so hard to treat. And in this slide, okay, we just shows the multifactorial causes of fatigue. On the left-hand side, you can see, okay, biological contributors, and many of these mechanisms, okay, tends to overlap with aging, right? Such as chronic low-grade inflammation, mitochondrial dysfunction, sarcopenia, sleep disturbances, respiratory compromise, nutritional problems. And COVID-19 simply amplifies many of these, okay, known mechanisms in aging through cytokine release, oxidative stress, and deconditioning. And one important thing to note is that autonomic nervous system abnormalities such as dysautonomia, okay, can worsen exercise intolerance and contribute to cognitive fatigue and physical fatigue. And on the right side, we see important psychosocial and demographic risk factors, such as psychological distress, pre-existing comorbidities, females, older age, financial difficulties, all contributing. So when we look at, okay, mood, cognitive impairment, and fatigue, there are many factors that were very similar across all these domains, right? Such as females, older age, having severe acute illnesses, pre-existing medical and psychiatric conditions. And interestingly, as I mentioned earlier on, children seem to have a lower incidence of all these symptoms, post-infection, so which may reflect differences in terms of the immune response, resilience, and symptom reporting. Then when we interpret the literature of post-COVID, okay, studies, we have to understand that many of these samples were highly heterogeneous, of different age, different severities, different countries, varying comorbidities, inconsistent treatment and exposure, different assessments and time points. So making it very hard to compare findings directly. And many of these studies did not really document very clearly whether patients had pre-existing psychiatric symptoms or cognitive impairment. So we do tend to risk either over or under reporting of some of this impact. And many of these studies, they actually reported using screening tools such as MMSE and MOCA, or maybe even telephone-based, assessments. And they are not really that robust, rather than a real comprehensive neuropsychological assessment. So they may miss subtle deficits, especially in processing speed and executive functioning. And lastly, we do need more longitudinal data to see how things will change with time. And many of the studies did not account for confounding factors that can affect cognition, mood, and fatigue, such as besides our psychiatric illnesses, medical conditions, but also in terms of treatment. Like for instance, steroid use, can also affect mood changes, agitation, psychosis, hydrochloroquine, chloroquine, all this have been linked to irritability and psychotic symptoms, those that we use to treat many of these chronic illnesses. So how do we actually manage all these conditions and symptoms? I think firstly, right, prevention remains a key. So vaccination, as we all know, helps to reduce the risk of COVID-19 syndrome. And then emerging data has also shown, okay, antiviral treatment maybe, and even metformin has been found to lower the likelihood of developing persistent symptoms, okay, although findings are still evolving. And it's also important, okay, to rule out alternative, okay, psychiatric and medical causes for some of these symptoms because you don't want to misdiagnose. So things like thyroid dysfunction, anemia, sleep disorders, depression, or any other medication side effects. And of course, for people who are experiencing okay, mood symptoms, cognitive symptoms, medications, has been found, and potentially medications that can alter some form of cytokine inflammatory processes. So in terms of the choices of psychotropic medications that I have personally used, okay, so it's really based on okay, targeted okay, symptom profile okay, experienced by patients. So if patients experience decreased energy, anhedonia, decreased motivation, and then with some mood problems, I would actually use activating antidepressants such as fluoxetine, venlafaxine, desvenlafaxine, or bupropion. But we do have to bear in mind that if we use activating agents, there's always this risk of overactivation, okay, paradoxical anxiety, loss of appetite, insomnia, irritability. On the other hand, for patients okay, who are more who have problems with sleep, then we may want to use sedating antidepressants such as fluvoxamine, mirtazapine, agomelatine, amitriptyline. And of course, we can also add okay, circadian rhythm okay, agents such as melatonin and lemborexant. But of course, bear in mind okay, the risk of oversedation and as a result of that leading to secondary memory complaints. And some patients, because of the anticholinergic side effects of medications, may actually also complain of some so-called memory issues. Then for cognitive issues such as brain fog, of course, we can use stimulants such as methylphenidate, lisdexamfetamine, or maybe even modafinil has been used to treat brain fog and fatigue. And we can also consider something that is even safer, such as vortioxetine, which is a multimodal antidepressant that has been found to increase BDNF levels. But bearing in mind that any stimulants, once again, can lead to overstimulation, irritability, loss of appetite, insomnia. Then benzodiazepines and hypnotics have to be used cautiously because these are commonly used to treat anxiety and sleep issues, even for non-COVID patients. But the risk of dependence, oversedation, and cognitive impairment have to be emphasized. Studies have shown that low-dose naltrexone have been used off-label to improve persistent fatigue and brain fogs. And this is an opioid antagonist, but it also acts as an immune modulator and specific antagonist for toll-like receptors on immune cells. But I have not personally used that for long COVID. D3 is something that's very simple, to add on, in terms of supplementation. And in fact, that most of us are deficient in vitamin D3, even though, we may be under the hot sun, right? So all this has been found to attenuate inflammatory effects. Then in terms of physical therapy, so things like aerobic training, strengthening exercises, diaphragmatic breathing techniques have been found to be useful. And of course, not forgetting our psychosocial interventions, such as CBT, mindfulness practices, problem-based learning, stress reduction techniques. But of course, bear in mind that cognitive and emotional overload can sometimes happen with some of this training and avoiding excessive physical exertion. So at the end of the day, really no one size fits all. Then this slide just shows that yoga has been found to be quite helpful, and specifically the practice of breathing regulation has been found to help with functioning capacity and in fact also overall immunity. Then Tai Chi, right, which helps to improve blood and energy flow, has also been found to be quite helpful as well. So in conclusion, right, so clearly, mood disturbances, cognitive impairment, and fatigue are real and very prominent issues post-COVID infection. And it is important for us to be mindful of comorbidities, of medical, psychological, and social interactions that can exacerbate or perpetuate symptoms. And I think one of the key feature of management is just simply empathetic and supportive, because many people, right, may think that all these patients are malingering. They don't really understand them, and even doctors themselves sometimes may not understand and think that people are just malingering with secondary gains. So care should follow a biopsychosocial approach. There's no single strategy, no single treatment. And of course, lastly, we do need to follow them longitudinally over time and then validating that experiences, offering structured holistic care. So with that, I end my presentation and I thank you for your time. Thank you.
All right, so we'll go ahead and pass it over to Cynthia Kim. Give me just a second. I'm going to share her slides from my screen.
Thank you. And Dr. Ho, that's amazing. I learned even more than I thought I learned in the process of looking at all of this at a larger level. And I think that there are so many factors of complexity that go into this. And my goal, what I would really like to focus on is sort of that biopsychosocial perspective, which I think dovetails very nicely. You covered the epidemiology exquisitely, right? And I could never do that justice. But you can go ahead and advance to the next slide. No disclosures. So what I really want to do is remind us all that this is not our first rodeo with diffuse chronic medical presentations and conditions. We've been here before. If you think about the continental US, many other countries and cultures have been here before with regard to epidemics, pandemics, things that have become endemic in terms of chronic illness. And we see the same patterns unfolding. But for all of that history, I just really want to bring us back and say, we still haven't really, as a medical society, even a mental health field, we haven't really figured out how to fully wrap our heads and hearts around how difficult these things are to define and how to talk to patients, but more importantly, talking to patients' families, coworkers, employers, in all of the arenas that our patients have to function psychosocially. There's just layers and layers of complexity there. So that's what I hope to focus on a little bit more, like how do we address that piece of it? So my goal is to reflect just very briefly on our historical understanding and treatment of diffuse comorbid medical and mental health conditions, because we still haven't really figured it out yet. What is currently known about the interaction of COVID and mental health in general, which Dr. Ho, again, went into exquisite detail about. My focus is really the biopsychosocial impact and maybe some newer approaches to how to understand and treat from a best practice perspective that is beyond the technical sort of what medication do I prescribe, what kind of treatment do I send this patient to, but how do we wrap our heads and hearts, like I said, around what's going on with this patient? How do we communicate with the patient and their family in all of their spheres of existence? How to live with this? You can advance. So lockdown memory lane. The intersection of acute and chronic impact of COVID with mental health really harkens back to almost every other diffuse condition, unspecified set of psychiatric or behavioral symptoms encountered during other epidemics in public health crises. In 1917, for example, encephalitis lethargica, sleeping sickness, right, which wasn't just a vestige of, it was studied probably most prominently around that time because of the so-called Spanish influenza epidemic, right? However, this appeared long before that, but we didn't really see it show up in the literature until about 1917 with that epidemic. Pandas sounds like cute, fuzzy, furry bear creatures, right? No, pediatric autoimmune neuropsychiatric disorders. That's plural on purpose because, again, we're talking about neuropsychoimmunology, which invokes nearly every organ system of the body, every brain structure. So we've got all of the architecture involved. We've got all of the chemistry involved. And so it's not a homogeneous sort of phenomenon at all, as Dr. Ho very well said. Next slide. So what we think we know so far, about 3 to 6% of the population with COVID infection will develop a range of symptoms that we affectionately call long COVID, right? Everyone has their different monikers for this. The World Health Organization has tried to gentle it a little bit by saying it's a post-COVID condition. Others, including the NIH and CDC, are talking about post-acute sequelae of COVID, right? So, but all of these things get at this idea of this is longitudinal, this is a marathon, this is not a sprint. A lot of folks, and I can back this up anecdotally, working with families in the ICU in the hospital who had to perhaps say their goodbyes via FaceTime to their loved ones who were heavily sedated and in treatment during the height of the pandemic. You know, trying to come up with a way to refer to what was happening to these folks was impossible at the time. Then some of them who miraculously recovered and were released and discharged were expected to just go back to life as normal and sort of pick up with who they were and how they were functioning before. And I think none of us knew how to address the debacle that ensued with that, right? So these terms really, you know, they scratch the surface. Again, we're talking about 50 or more different kinds of symptoms or signs affecting most organ systems, right? We know that the risk of incidence and intensity of impact are definitely related to things like female gender, socioeconomic status, race, right? Because of trauma due to poverty, trauma due to racism. All of these things challenge our neuroimmunology at baseline. So whatever the person came to the table with pre-infection is still very much at play. We know the severity of infection has a huge impact, vaccination status, of course, and then the history of any other types of chronic inflammatory metabolic diseases or conditions, such as diabetes being the most well-known. But Dr. Ho, I love that you are perhaps one of the first psychiatrists, believe it or not, who I have heard echo my sentiment that depression is an inflammatory condition, right? So it makes sense when we give things in Germany, when they give metformin to people who are depressed before they give them SSRIs, and a significant portion of those folks will go on to improve in their symptoms. Wow, there's a lot there. So thank you so much for validating that for me personally. Very gratifying. You can advance. Again, I don't think this can be said strongly enough. We're not talking about just profound fatigue. We're talking about almost a level of fatigue of amotivation, avolition, right? So not decreased motivation, but literally my hand wants to pick up the cup of water and I can't make it happen. Things are not firing smoothly enough or quickly enough to make that happen. It's almost like what we see in certain forms of psychosis, right? Again, talking to this idea of neuroinflammation perhaps being at play there. But we cannot underestimate the social impact of what it looks like to have someone who was a single mom running around taking care of 3 kids, working 3/4 or full time, and doing all of the things on the side and doing all of the emotional and psychological labor, who is now unable to get out of bed, unable to tolerate interacting with her children for more than 15 minutes at a time, right? We cannot understate the impact and the cost to everybody involved with that patient's care. Mood changes, depression, irritability. Yes, that's an understatement. Changes in sensory perception, mostly visual, olfactory, and gustatory. But again, the social impact of that is huge. We can understand the pathophysiology of that on one hand, but on the other hand, to no longer be able to taste or smell your favorite foods, right? To no longer be able to realize if your kid with a peanut allergy is maybe getting something that smells like peanut oil, right? There's all kinds of social implications here. So just those changes in sensory perception are disorienting enough for the average person. But when you think about the social impact of how often and to what extent those things will play out in a person's day-to-day life, the mundane stuff, that's huge. And high level of functional impairment due to that synergy, right? You have the illness, the phenomenon of COVID-19 itself, and everything that comes with that, all of the insults that come with that, and then this biopsychosocial impact. Those are like 2 people in a relationship, and the synergy that pops up is greater than the sum of the parts in ways that we're just beginning to understand. You can go ahead and advance. So I am not going to belabor the neuropathophysiciology of this. It's heterogeneous, right? It's very heterogeneous. It's multifactorial, predominant theory being neuroinflammation, which affects everything. Exposure, just getting sick, right? We know activates the immune system, leads to that cytokine storm phenomenon, lots of collateral damage to tissue. Sequestration, perhaps, and maybe this is why Paxlovid has been shown to be so effective, right? If remnants of viral material, proteins, are encoded or embedded into neural tissues like glial cells within the nervous system, it's almost like a phenomenon of like HIV, right? Where they're hijacking healthy cells and replicating or staying dormant or staying in the backdrop within the brain, heart, gut axes, but then also within the periphery of the nervous system. And then vascular has also been proposed as a main mechanism of action, if you will, inflammation of the blood vessels themselves throughout the nervous system, weakening the blood-brain barrier and allowing unchecked penetration of those immune cells into neural tissue, amplifying inflammation in other cells. Go ahead and fast forward. It's not an accident, right? I love, again, the exquisite level of detail at looking at the very close-up view of what is happening in the activation of all of these things. But if we step back a little bit, we're talking about multiple pathways for attention, motivation, rewards, right? The internal hit of dopamine that we get when we get a hug from our kid, all of that gets hijacked, right? Because it's all innervated and connected in the connectome through those dorsal and ventral striatum of the basal ganglia, right? And the basal ganglia are innervated with other key brain areas within the limbic system up through the higher cortical areas of the brain, also affecting mood and cognition. So what I tell patients, instead of saying neuroinflammation in any of these areas leads to bottom-up and top-down deregulation and integrated aspects of your mood and behavior, I say the hip bone is connected to the thigh bone. So everything is interacting at all times, and that's why there's so many things at play here. You can go to the next slide. Pretty picture of the limbic system. Again, this is not the micro view as Dr. Ho shared, but like the 10,000-foot view, sort of looking at the hypothalamus implicated in things like sensory relay, memory formation, the amygdala, the so-called emotional center, more primal emotional center of the brain, but also very much innervated with parts of the higher cortical areas that are responsible for memory, decision-making, emotional responses, regulation, right? We have that autonomic regulation in our nervous system that tells us how to respond to things that feel internally and externally threatening. And our higher cortical areas are supposed to be making an interpretation. So if the wires are getting crossed there, all of a sudden, all of the things that look like they could be a saber-toothed tiger coming to eat us are in fact the saber-toothed tiger coming to eat us. Basal ganglia, control of movement, fine movement in particular, right? So people are noticing quote unquote clumsiness. I'm clumsier than I used to be. I'm less coordinated. I'm clipping walls as I walk by. None of that is accidental, right? All of these things are interconnected. Learning habits, even the way that someone uses their executive functioning in their prefrontal cortex to organize how they want to approach learning or approach doing a task, all of that has shifted in qualitative and quantitative ways that the person has not been prepared for and wouldn't know just based on the virus status itself. You can go ahead and go to the next slide. So this is what I really, really want to focus on, the stigma, right? We, especially in family medicine, our residents, we evaluate our residents, their family medicine milestones say, there's a whole subcompetency devoted to, does this person have the ability to wrap their head and heart around and talk to patients effectively about diffuse medical conditions? And that could be anything from unexplained hypertension to fibromyalgia to chronic fatigue syndrome. And traditionally, medical culture tends to poo-poo these things and create a lot of stigma around it. You just have to work harder. You just have to do more of that physical therapy. Take the stimulant medication and you'll feel better. But in the case of long COVID, these protracted symptoms and the impact of those emotionally, psychologically, behaviorally lingers far beyond what we would expect to see out of a typical recovery period. And much of that stems from lack of understanding, misunderstanding, misattribution of what is essentially internalized etiology, which is not immediately visible or measurable with a lab test. Right? We can't give someone a test that measures their motivation. We might be able to do that on a neurological level, but how that translates to then their psychosocial behavior at work, at school, in family relationships, in conversations, those are very different things. So our patients are already coming to the board with a lot of doubt, disbelief, and negative social impact that they have internalized. And then on top of it, many of them also came to the table with other chronic illnesses, whether it be diabetes, chronic fatigue, like I said, fibromyalgia. In New York, we had the phenomenon of chronic Lyme's disease, which half of our doctors believed in and half of them didn't. So patients themselves got a lot of mixed messages about what was really going on and how to understand these things. And I think, again, after all of this time from the early 1900s on, we still haven't really figured out a great way to tell patients it's not just all in your head. But because this has been sort of the traditional path to approaching, let's treat the symptoms, for example, it tends to limit our treatment approaches and best practices to the more obvious targets, the symptoms themselves. You can go to the next slide. So treatment as usual might look like, hey, your mood is worse, let's give you an antidepressant. And yes, that can help. But we know, for example, at baseline, with or without COVID, giving a patient an SSRI is kind of like a 50-50, chance that it's going to have some efficacy, even at an adequate dose and titration and regimen, right? We can give someone else another medication in that same class, and there's another 50% chance that they're going to respond to that medication, perhaps not even fully. That is because depression itself is so heterogeneous, right? And most have not really accepted that yet. We still tend to treat to diagnosis, unfortunately. And so when we're trying to target symptoms of long COVID, I think a lot of us, even though we're talking about doing it differently, tend to default back to treatment as usual. Anti-inflammatory medications obviously can be helpful for some of those more acute symptoms that go with long COVID, but can definitely worsen. I had a patient recently, first I've ever seen in an outpatient setting, become acutely manic after being put on systemic anti-inflammatories for a period of time to treat her COVID symptoms. She didn't see it. Doctor didn't see it right away. I saw it after one conversation with her. I said, oh boy, we got to get you off of that anti-inflammatory. So sometimes the cure is worse than how that goes. Stimulants to address fatigue and boost cognitive function. But we know that there's a lot of autonomic dysregulation, as Dr. Ho shared so eloquently with long COVID, the phenomenon of long COVID, so that if we're giving stimulants, we really run the risk of overactivating increased anxiety, increased autonomic dysregulation, right? Because those are not selective. They're just going to stimulate the whole nervous system at large. So that can become problematic. So even though we boost someone's attention and focus, they're now having panic attacks throughout the day and thinking that they're having cardiac effects, right? So, and all of the above. Psychotherapy. I'm a psychotherapist by trade. This is what I do. This is my tea. This is my thing. And I'm going to tell you that most of the patients who I have seen, there's very little literature on this, unfortunately, which we definitely need more studies on. But most of the patients that I have seen post-acute COVID cannot benefit from cognitive behavioral therapy. We joke in family medicine, at least, that the board question answer is always an SSRI and/or cognitive behavioral therapy if you have to choose. It's one of those two things. But in this case, I'm sorry to say, I'm talking against my own kind here. I'm betraying my tribe, but most patients are not going to be cognitively and physiologically in a place where they can tolerate or even really benefit from CBT at first, right? CBT is still the answer. It's just not option number one. Any kind of talk therapy can help normalize the experiences, rewire the architecture to some degree over an extended period of time. And again, the time frame for that is going to look even longer than our patients with routine garden variety mental health presentations, right? So if a combat veteran needs about a year to 2 years of cognitive processing treatment for trauma-focused therapy, a person with post-acute COVID is going to need probably about 3 years before that you really start to see the benefit. How long does insurance want to pay for psychotherapy? Right? Before we have to start filling out those threshold override forms. So old approaches just really are not cutting it right now. Next slide. So what can we do? Novel approaches. Let's stop treating to diagnosis and target treatment to mechanism of action of the symptom. We talk about mechanism of action with regard to medications, for example, or even certain types of psychotherapies, right? Why is CBT effective? What's the mechanism of action? We are literally rewiring the brain. But we often don't extend that to this idea of what's the mechanism of action of the symptoms? What are the symptoms trying to do? Because all behavior even medical behavior of the body that is involuntary is an attempt to adapt to a particular set of challenges at a particular point in time. We talk about this socially. The social corollary of this is, why would somebody drink when they're going to lose their job and lose their family and develop addiction? It's adaptive. That alcohol is actually providing an adaptive coping mechanism for that patient, right? So the virus itself and the cascade of symptoms are all, if we start to think of those as adaptations to what's going on internally, we can start to identify the mechanism of action, and we have a much better shot at making recommendations about not so traditional targets for treatment, right? So for example, yes, target the monoamines. That's what our SSRIs do. But even more importantly, think about that glutamate to GABA balance, right? Glutamate is excitatory, inflammatory. GABA is calming, is regulatory. We can get at that through some of our multimodals, which I love that Dr. Ho referenced. 40-oxetine is not a brand new medication, but it's often overlooked. But not only does it hit on multiple types of serotonin receptors, for example, it also hits on NMDA receptors, which has a huge role in whether the glial cells are hijacked and converted by the virus and turned into the bad guys, so to speak. Ketamine, dissociative and pathogen used now in trauma therapy. This is a form of trauma to the body. Having acute COVID, having this protracted set of symptoms and cascade of phenomenon with long COVID is absolutely a form of emotional, psychological, behavioral, and physiological trauma within the body. And so helping someone use a medication that can reduce inflammation, stimulate multiple monoamines at the same time, hit on those NMDA receptors, and promote brain-derived neurotropic factor. Amazing, right? Kind of, but very not accessible in the outpatient setting unless you are certified to prescribe this ketamine, right? So lithium, an oldie but a goodie. How does lithium work? Lithium is great for bipolar disorder, for psychosis. Guess what's going on in those disorders? Inflammation, right? So lithium has been shown to be neuroprotective in those kinds of situations, and there's no reason to think it wouldn't be here. And initial emerging literature suggests that it also is neuroprotective, can help over time improve memory function, improve executive function, attention, focus, all of those things, as well as help with mood stabilization and elevating mood a little bit. PPAR gamma. Okay, I have to totally like reference my notes. Peroxisome proliferator activated receptor gamma. Again, involved in this idea that the virus comes in and it hijacks our very own protective brain cell tissues and turns it against ourselves and creates this cascade of symptoms or contributes to it, right? So this can help convert those pro-inflammatory microglia and provide protection and make them anti-inflammatory. GLP-1 inhibitors are being studied for use. Ozempic, good old-fashioned Ozempic, not just for weight loss anymore. We know that it helps with insulin resistance in people with diabetes. Again, what is the mechanism of action of insulin resistance? Inflammation, when you really think about it, right? Inability for that glucose to get into the cells it needs to get into. And that doesn't just happen in the periphery of the body with regard to glucose getting into blood cells and providing fuel for the body to do things, but the brain, right? If the brain is literally starved if we know metabolism of glucose in brain tissue and brain cells is also compromised, we can think about similar mechanisms of action for reaching that and reducing that inflammation. COX-1 and 2 inhibitors. There's a newer medication on the market, not brand new. It is not available as a generic, but there are patient assistant programs for this, and I have successfully advocated for patients to have access to this medication called Auvelity. It's a dextromethorphan bupropion combination medication that helps increase GLP-1 release in other parts of the body, but interestingly in the bowels. So this idea of the gut-brain axis again, right? Very important. 5-HT2B meds, which is often overlooked in terms of monoamine treatment. Which serotonin receptors do we really want to target? We can get at those microglia and recode them a little bit more directly through medications like viloxazine, cariprazine, brexpiprazole, sometimes called atypical antipsychotics, but we want to think of them as multiple monoamine modulators. They don't just amplify, they amplify dopamine in certain receptors and they squash it in others where it's not as needed as much, right? So they are a little bit more selective, especially the newer formulations of these medications, which are within reach in primary care, for example. Sigma-1 receptor meds, fluvoxamine, oldie but a goodie, often overlooked, traditionally prescribed for OCD. Again, my shout out to pandas before, an OCD-like symptoms is not a coincidence, right? When we have inflammation and it affects the brain, we see these sort of repetitive sort of patterns of misfiring in the brain and the rest of the nervous system. And medications that help with the behavioral symptoms that we see with things like OCD can help with the underlying mechanism of action that is driving those feedback loops that affect other aspects of mind and behavior. Next slide. I'm not going to belabor this. That's outside my scope. Keep going. So best practices. Normalize, normalize, normalize. This is not in your head. That is so important to tell patients. Things that we would typically think of like this, we would call psychogenic, right? You're depressed because you were sick and you were out of work for a long time. Of course, you're going to be depressed. No, you're depressed because you were sick and that is making it hard for you to get well. This is not just psychogenic. This is neuropsychoimmunological in origin impact. I blame both my German ancestry and my autism for wanting to put lots of words together to make newer words. Forgive me. Thank you for indulging me. So important to have a sense of where this person's baseline mental health picture was, which is often very difficult to piece together. Especially within certain cultures, we're going to see the somaticizing aspects of functional impairment to someone's emotions and behavior before we see the mental health piece of it. People are less likely to say, I've been depressed forever now. More likely to say, I just can't get out of bed. I'm not myself. I don't feel like myself. I'm tired. So records review, history, and definitely whatever baseline assessment we can get our hands on is really helpful to create that big picture of what was this person like going into COVID, perhaps? What were they like during the most acute phase? And what are they looking like now, a month out, 3 months out? This is a marathon. It is not a sprint. And we don't typically do that well longitudinally in terms of mental health assessment. We should, but we often don't. Screening for current comorbid mental health symptoms, right? Which came first, the chicken or the egg? Anyone who came into the picture of COVID with an affective disorder, depression, bipolar disorder, that is certain to become worse in a lot of ways. And generalized anxiety, psychosis, substance use, right? The most garden variety sorts of things that we tend to see in most medical settings. It's important to evaluate those internalizing symptoms too. What is that person telling themselves about guilt, shame, attribution, how they got sick in the first place? So many variables there at play. And I know we're out of time. So the punchline is always that a combination of medical and behavioral health approaches are always going to be best. But what I suggest, and this is a talk for another time, is integrated behavioral health approaches to providing wraparound support for this person, but not just this person, for their family, how to advocate for them at work. So you need a case manager, you need a social worker, you need a psychiatrist. It's kind of an all hands on deck thing. And the traditional mental health model of let's send this person to therapy to address their depression and give them a med, it's just not cutting it. So if you'd like to hear more about integrated behavioral health in this population another time, I would be happy to go more into that. Thank you.
Thank you both. I know we're out of time, Melissa, but people can write to me and Cyrus and Cynthia. It's okay if we reach out to both of you. People can write to me, and I'll write to both of you regarding some of the questions. I did have some questions about neuroinflammation, and both of you beautifully put down, the psychiatric issues of neuroinflammation. I think that's a hot topic, and my own question was whether or not there's ever been an intervention of using families to try to help stabilize this biopsychosocial impact. But I'll leave it to Melissa if we have time or not. But I'll ask you by email. But for people on the chat, if you wanted to, you could write to me, Dominic C at hawaii.edu, and I'll reach out to both of them.
Okay, perfect. Yes. I was going to say the exact same thing. If anybody has any questions, you can forward them to us and then we'll reach out to them to try to get you the answers. Thank you everybody for sticking around with us today. Our next session is going to be on November 11th, and it's the neurological complications and brain fog in long COVID. So thank you for coming and hope to see you there.